Thank you very much indeed, Stephen, for that introduction, and thank you for inviting me. I know I'm the last in a long list of speakers over 2 days. I'm sure you're all exhausted, but I will speak quite quickly, so hopefully we get as many questions as possible. We used to be marooned from the bells in this theaterette, and there was once an occasion where there were 5 or 6 of us and we didn't hear, and there was a big disaster. So now I think they've got much noisier bells, so if you hear them, you will hear them. Can I acknowledge the traditional owners of the land on which we meet and say that as Australia's Federal Health Minister, like I am sure all ministers preceding and succeeding me, closing the gap in Indigenous life expectancy must be of the highest priority. So, sustainability of the health system, I guess that is the one word that comes into the lexicon when we talk about health. And I mention that first up because sometimes I hear my political opponents sort of diminish the argument a bit by saying, well, sustainability doesn't mean anything because if you're prepared to pay, something is sustainable. But my favourite saying in health is if you can't pay for it, you can't deliver it. So, of course, we are constrained by the fiscal circumstances we find ourselves in. Having said that, I don't see that as doom and gloom because I think that you make the most efficient system when you have, in a pure economic sense, an allocation of scarce resources. So often, I don't dream of a world where there's unlimited money because we actually wouldn't build the best system if we had unlimited funds. 30% of expenditure inside health, according to an expert who spoke to the South Australian Parliament recently, or the South Australian Government recently, 30% is waste inside the health system. That was a South Australian Labor government's expert. So we all know that we can do better with the health dollar. Ensuring our health system has flexibility is key. Improving the performance and structure of the health system so we can continue to deliver better health outcomes is most important. In other words, we want to ensure that our universal health system and its cornerstone Medicare remain healthy far into the future. Australia is the envy of many nations in that we have one of the most affordable, accessible and comprehensive healthcare systems in the world. And by world standards, our health system actually performs very well and achieves good health outcomes moderately efficiently. As I said, there is room to improve. Like other parts of the world, of course we face challenges. Over the past 25 years, Australia's total health expenditure has increased from 6.5% of GDP, with the latest figures from the Australian Institute of Health and Welfare showing expenditure topped 10% of GDP for the first time ever in 2014-15. And while the rate of growth has slowed in recent years, it's still growing faster than the economy. In the longer term, this trend is not sustainable. This is driving our reform agenda. We need to find ways to work smarter with limited resources and ensure our health system is robust, high-performing, but flexible enough to meet future challenges. Innovation and greater efficiency also mean resources can be allocated where they're urgently needed to vulnerable people and communities. We're not alone. Other countries are also considering similar reform processes to ensure the sustainability of their health systems. We, along with many other countries, face additional challenges that will continue to uniquely test us into the future. Our population is ageing rapidly. By 2036, almost 20% of our population will be aged 65 and older. We have a high incidence of chronic disease, with Indigenous Australians particularly vulnerable. And our geographic spread continues to challenge health service delivery in rural and remote communities. Digital health is showing some promise in breaking down these barriers, and I'll come to that later. More broadly, our health system itself is complex, which is a significant challenge in delivering a more cohesive and consumer outcome-driven health system. It's a mix of providers who are funded both publicly by both federal and state governments and privately. This can lead to duplication of services, gaps in care, with limited communication and therefore integration. Added to this are rising consumer expectations about the healthcare they receive and rapid advances of healthcare technology. Our health reform agenda is wide-ranging but essential. If we do nothing now, our health system may struggle to meet our basic needs in the future. One of our biggest areas of health expenditure, Medicare, is our first priority. Our Medical Benefits Schedule Review Task Force is one of the 3 priority areas under our Healthier Medicare initiative that will help ensure the long-term sustainability of our health system. This review was long overdue. In fact, there hasn't been a comprehensive review of the MBS since Medicare was created 30 years ago. It will ensure the 5,700 items on the MBS are aligned with contemporary clinical evidence and practice, and ultimately this will improve outcomes for patients. The review is also important from a financial perspective, with the Australian government investing over $20 billion in the MBS last year, representing about 30% of total Commonwealth health expenditure. That said, I want to make it clear that this process is not about cutting services or reducing funding. More than 300 clinicians and approximately 40 clinical committees and working groups, led by the former Dean of the Sydney Medical School, Professor Bruce Robinson, have been reviewing the MBS line by line. The consultation has extended far beyond this, with many more health professionals and patients providing input, written submissions and an online survey. Last month, I released the Task Force's interim report. It identified that the vast majority of health professionals surveyed agreed that parts of the MBS were out of date and needed to be reviewed. The task force, the MBS task force, has its work ongoing, and I want to thank the dedicated health professionals on it. Reform of our primary healthcare system is another essential task that will deliver more efficient and effective healthcare. Primary health networks began in July last year. PHNs, there's 31 across Australia, and they're a departure from the one-size-fits-all model of healthcare from Canberra. This national network is charged with improving patient outcomes. There's 6 key areas, at least, where they have to report back to me to say that people's health is improving. Their predecessors, many of you may know, were called Medicare Locals. They were the previous government's iteration of this regional body. I believe our reform is where we need it ultimately to go. The PHNs commission the dollars. I see them as an invisible skin between the dollars and the service providers, and their job is not to provide services, not to be medicos, but to make sure that the dollars from government are used on the ground in frontline services in the best possible way so that we get the best value for our health dollar. And as I said, very easy with these sort of organisations to get very process focused. So lots of things happening, lots of activity, but that activity is not relevant if it doesn't lead to patient outcomes, and that's my key focus with the primary health networks. A number of them will play a pivotal role with one of our key reforms, which is healthcare homes. The healthcare home model puts the patient at the centre of their care, helps the patient navigate their options, but most importantly, attaches that patient to a usual general practice. So we've come a long way since the old days of the old-fashioned GP who knew you from cradle to grave and was there at your bedside in your last days explaining to the hospital staff what your wishes were. I mean, that's a wonderful model, I have to say, but we don't have that anymore. But we want to introduce as much as possible that regular GP and that regular practice. That's what healthcare homes does. Top 25% of patients in the most chronic and complex disease categories will be enrolled in a healthcare home and with a usual GP or GP practice. And that GP, instead of being paid in a transactional way via Medicare, will actually get a quarterly bundled payment to allow them to look after the patient, the whole of the patient, including all of the allied health services they may need, the primary care nursing they may need, the counselling they may need if they have mental health issues, the link between them and their aged care provider, and allow them to do it in a way that the practice decides it wants to do it, knowing its patients, knowing its workforce. Medicare kind of belongs 9 to 5, as I said, transaction-based. I talk to doctors, the younger GP who says, I'm quite happy to go home and, do a bit of work. For example, on a patient who's been newly diagnosed with type 1 diabetes, I'll tell them to text me in their BCLs for the last fortnight. I'm there if they need me, just in that very early, difficult stage. At the moment, we don't have a remuneration model for that, but the healthcare home model is about the doctor being, unharnessed from the system that exists now. And I'm really excited about it. At the moment, the trial areas, there are 10 primary health networks that are trialling healthcare homes. It's 65,000 patients in 200 practices that will be enrolled. We will test the model over the next 9 to 12 months, and then it will start, hopefully, in a much bigger way, much broader way on the 1st of July next year. Earlier I mentioned the challenges facing us because of Australia's geography. We have a unique challenge in delivering good, strong, equitable healthcare everywhere. Our Indigenous communities, sometimes in very remote Australia, need very good health services to protect their health, to meet their needs, and they need a high quality workforce. I always say of rural and remote health, there are great challenges, but there are great rewards, and you only have to talk to anyone who works in that area to get a sense of those rewards. But the challenges encourage us to think outside the square, to be innovative, and to come up with solutions that work. We have to provide the conditions to attract and retain the workforce we need. That's a big piece of any health minister's task. I'm ably assisted by my Assistant Minister, David Gillespie, who's an Assistant Minister for Rural Health. Get the workforce in the right place at the right time as needed. And digital health has much to play in this space. I read with interest a recent article on the ABC website where the University of Sydney is trialling a smartphone app which replaces a traditional ECG machine to detect atrial fibrillation, a disease responsible for a third of all strokes in Australia. The test involves touching connectors on a mobile phone to get a reading in as little as 30 seconds. Health workers can then transmit the results electronically to a specialist either in Sydney or with a visiting service, who can then arrange any necessary follow-up assessment and treatment. It's an encouraging trial and it's a great example of innovation in digital health. More broadly, digital health initiatives such as My Health Record will become an increasingly important way for Australian patients to share their health information with treating healthcare professionals. An individual health record that is electronic, it's digital and attaches to you, the patient, is, I think, one of the key remaining microeconomic reforms in health. Believe me, we're leading the world in this. If we hurry up and get through the next 12 months, which I'm keen to do, so that everyone's health record is automatically switched on, unless you say, I want it switched off, and doctors and clinicians upload your records onto that. So imagine you turn up, we've got a state-based system of public hospitals. You turn up in the emergency department of a state where you don't live, which doesn't have your records. You can't speak. You might have had an allergic reaction, and you've got your Medicare card, but it doesn't tell the emergency physician anything. But what I see is that the emergency physician, if you have an e-health record, and you should all go out and get one, by the way, if you don't already, you should say to your doctor, why haven't you signed me up? There's a break glass function on that actually allows that emergency physician to look at your records and find out something that may tell them how to save your life. Now, that's just, a very important feature, but you consider how many times patients get the same scans, same blood tests. Some hospitals say, we do them all when you come in because, we like to have it all on our own letterhead. But all of that is, costing Medicare. To have the results sitting in one place, for every clinician to look at them, is absolutely vitally important. So the My Health Record is held by about 17% of Australians, but we are encouraging doctors with financial incentives to sign more and more up every day. We also have healthcare provider organisations registered with the system. We have hospitals, we have aged care residential services, and of course we have pharmacies, because your medication is a vital part of your health record as you, the patient, travel through a variety of different providers. We've got a new digital health agency which is going to trial and implement our healthcare homes, be involved in My Health Record, and effectively lead the way and make digital health attractive to the consumer in a way that perhaps it hasn't been before. I see Sure, the health record thing is important, but it doesn't necessarily excite people. They think, well, I need to have this. This is important for me and my family. But when you consider the availability of apps, of digital interventions, of ways that you can be supported via your mobile phone platform to engage and become more interested in taking more responsibility for your health, I think there are some really, really exciting opportunities. I'm going to stop talking there, Stephen, because I'm a politician. I can talk under wet cement. I hope I've given you some sense of the agenda in health, but I'm really delighted to take your questions. Thank you.